We are live now, sir.
Okay.
Thank you. Good evening to all the respected dignitaries, my seniors and colleagues. I, Dr. Neha Singh, Secretary IP Raigad. On behalf of Maha IP and IP Raigad, I welcome you all today to our Feb month of journal journey, reciting the famous lines, if you are not willing to learn, no one can help you. And if you are determined to learn, no one can stop you. I welcome Maha IP President Dr. Sanjeev Joshi sir, Secretary ma'am, Maha IP Dr. Renu Boralkar ma'am, President-elect Dr. Vinayak Patil sir, Central IIP Secretary Admin, respected Dr. Mahesh Mohite sir, Dr. Sanjay Deshmukh sir, Dr. Bela Verma ma'am, and all the Central IIP EBs of Maharashtra and Maha IIP OBs. I also welcome Raigad IP President Dr. Sachin Murade sir, past President Maha IIP Dr. Hemant Gangolia sir, respected Dr. Neeman Mohanty sir, Chairperson Maha IIP AHA Dr. Chitra Kulkarni ma'am, and everyone present for today's journal journey. I also welcome our esteemed experts of today, Dr. Anant Bendale sir and Dr. Swapnil Bishikar sir, and our presenters of today, journal journey reading, Dr. Tejas Hambir and Dr. Samruddhi Patil. So I would like to invite Raigad IP President Dr. Sachin Murade sir to welcome our Maha IP dignitaries, experts as well as all our attendees. Over to you, sir.
Good evening, everyone. Welcome all the dignitaries and Maha IP President Joshi sir, Vinayak Patil sir, and all the OBs and ABs. Now, this is the second journal journey of this year. And as we know, this is the program where the younger ones are nurtured by the seniors for presentation. At the same time, we are learning about the new guidelines or what is happening new in the field of pediatrics. In our today's topic, we have two topics. Yes, the last time we have discussed about what is new in a pediatric cardiopulmonary resuscitation. Now and today we are learning what is new in neonatal resuscitation. At the same time, home monitoring blood pressure. These are the topics which has been selected by Chitra ma'am and Mohanty sir. And I thank all the presenters for taking efforts to make this program successful. Over to Neha.
Thank you, sir. So now I invite Maha IP President Dr. Sanjeev Joshi sir to give his blessings. Over to you, sir.
A very good evening to all. Respected Monty sir, Jay sir, Gangulia sir, my dear friend Sachin, President of the Raigad branch, and Dynamic Secretary Dr. Neha, our Maharashtra IP Secretary Dr. Reno, all the EPs of the Maharashtra IP, OPs of the Maharashtra IP, the young guns, Dr. Tejas, Dr. Samruddhi, and the masters, Dr. Swapnil and Dr. Anant. I think everyone knows about the Raigad branch contribution. Of course, ये क्षमा तो जलाई थी डॉक्टर मोहंती सर, डॉक्टर जय सर और डॉक्टर गांगुली सर। और अभी तो मतलब इसकी रोशनी जो है पूरे महाराष्ट्र में है। And one of the ideal platform for grooming of the young researchers to deal with the latest changes and challenges in the field of Pediatric Science. So I also welcome all the attendees on the virtual platform. I again congratulate the whole Raigad team, Sachin, Neha, Chitra, and of course the mentors uh, for being part of the Maharashtra IP Academic Active. So without taking much time, over to you, Dr. Neha.
Thank you, President Sir, for your encouragement and admirable words of wisdom. Now I invite my dear friend and MahaIP Secretary, Dr. Renu Varalkar ma'am, to please give a few words of encouragement. Over to you, ma'am.
Yeah, thank you, Dr. Neha. Good evening, one and all. And it is the second journey as we are proceeding today to of the February month on the first Feb. And I wish all the best to the presenters, Dr. Tejas, Dr. Samruddhi, and all the experts who have joined and mentored them. And it is a great privilege to be here on the platform under the guidance of Dr. Gangulia sir, Dr. Mohanty sir, and Dr. Chitra madam, and the team IAP Raigad with Dr. Sachin sir and Dr. Neha. And also, I wish a good evening to my president, Dr. Sanjeev sir. And now he has just shared his vision. So, without taking any time, we will proceed towards the journey. Thank you so much.
Thank you, ma'am, for your words of wisdom and always your support to us. So now I invite MahaIP President 2022, Dr. Hemant Gangulia sir, to say a few words and his blessings. Over to you, sir.
Thank you, Neha madam. I'm very happy to see this journey of journal journey, and it's the fourth year. Thanks MahaIP team to continue with this journal journey for the fourth year. And I think so we should go for the scientific session. All the best wishes to the presenters and experts, and let us move ahead with the science.
Thank you, sir. So we request our attendees to please post their queries in the chat box, and in the end of the both the presentations, we will be taking them if there is time. Thank you. And so, friends, for today's session, we have two experts with us, Dr. Swapnil, MD Pediatrics, DM Neonatology from prestigious Institute PGI Chandigarh and Lokmanya Tilak Medical College and Hospital, Sion, Mumbai, practicing exclusively neonatology for last more than 10 years, and he is clinical director of KIMS Cuddles NICU Nagpur. Our second expert is Dr. Anand Mendale, practicing pediatrics for more than 27 years and has teaching experience of 19 years. At present, Sir is professor and HOD at Dr. Ullas Patil Medical College and Hospital, Jalgaon, and Yashasri Hospital, Bhusawal. Sir is also director of fellowship courses, MEU coordinator and PG guide, basic instructor of NRP and BLS, and resource faculty for many workshops. So let's start our first article, which will be newborn resuscitation, best practices and recent advances for the pediatric clinician. And our presenter is Dr. Tejas Hambir from IIP Pune. Sir is consultant neonatologist and pediatrician, experience in neonatology for more than 14 years. Currently, Sir is HOD of Neonatology, Jupiter Hospital, Pune. Sir has done MBBS DNB Pediatrics Fellowship in Neonatology from Rainbow Hospital, Hyderabad, and fellowship from RCPCH from Oxford University, UK. His area of interest is care of extreme preterms, developmental supportive care, and neonatal stimulation, neonatal ventilation, PPHN of newborn, and he's also national faculty for advanced NRP and neonatal stimulation. Our second article is accuracy of home blood pressure monitoring in youth, a systemic review and meta-analysis, and it will be presented by Dr. Samruddhi Patil from Savangi. Dr. Samruddhi has done her MBBS from Parvara Institute of Medical Sciences. At present, she is second year postgraduate student in pediatrics of Jawaharlal Nehru Medical College, Wardha, a dedicated student and focused on quality child care and improving knowledge in neonatal care and pediatric emergencies. She is keen to enhance clinical skills and contribute to patient-centered care through learning and practical experience. So now I request Dr. Tejas sir to please share his slides and start his presentation. Over to you, Tejas sir.
Thank you so much, ma'am. Can I start sharing?
Yeah, please.
Are my slides visible?
Yes, sir. You have to make it full screen.
Okay.
Yes, sir.
Good evening, everyone. Good evening, all the like eminent faculties and experts. And thank you so much, MahaIP, for giving this opportunity, as well as myself for giving and recommending my name. So, without wasting much of the time, we will go ahead with the scientific talk. So, today we are discussing about newborn resuscitation. The article which was given to me was about newborn resuscitation, the best practices and recent advances meant for pediatric clinicians. This was published in Pediatric Clinics of North America in August 25. So this is not a original article in the sense that it is not a research article. It is more of a guideline article. So there's a lot of things which it adds on to our day-to-day life. As we all are aware, I'm sure like all of you would be aware with the 8th edition of NRP. On your left, you can see the algorithm of 8th edition of NRP along with the targeted oxygen saturation table. This was actually been published in 2021 along with American Academy of Pediatrics. So what does this article add in that way? So the article basically adds the best practices which are based on the latest neonatal resuscitation program. It simplifies the practical aspect in day-to-day care, as well as it also tells about the emerging areas of science or research in neonatal resuscitation. So what I'm going to do during my talk is I'm going to break this algorithm into different sections and try to simplify the article in general so that everyone benefits out of it. Before going to the algorithm, we all know that whenever we attend, and we all have gone through this, that whenever we attend a resuscitation, there's so many factors which play a dynamic role in a newborn's initial resuscitation. The birth setting, level of neonatal care designation, the workforce availability, all these are dynamic resources for consideration when we are preparing for neonatal resuscitation. I might be the best person to resuscitate a 24-weeker, 25-weeker, or 28-weeker. But if the uh, area or the infrastructure is not supportive, it might not be the best outcome for the baby. So, lot of factors do matter. And when I say about resuscitation, it is not only into the delivery room. It can happen in emergency room. It can happen in postpartum room. The babies can crash in nursery, or they can also crash in neonatal intensive care units. So, as all of us, it is very important to understand and recognize each hospital's unique array of resources. We should be aware of available workforces. We should be aware of all the physical spaces where resuscitation might occur so that we can optimize equipment and educate all the potential scenario. As I mentioned again, I might be the best person to intubate a 28 weeker, but if I don't know where exactly is the OT or where exactly is the labor ward or what I should be doing if there is a twin delivery or whom I should be calling, it will be not fruitful. So all these parameters do play a major role. The goal of NRP is having a trained individual at every birth. Okay, so that is very important. Whenever there are additional risk factors for a delivery, it is important to have a hospital based system in place to ensure that we identify and assemble additional person with appropriate skill set with who can be helpful in the neonatal resuscitation. Means what? If the junior attends a delivery, he should have a clear idea where the senior consultant is available so that in case of emergencies or if there are additional help needed, he can immediately call one of them. So let's go ahead and talk about the pre-delivery consideration and preparation. So as you can see, before even the baby is born, there are a lot of things which go in the background. As we all know, before a movie is done, there's a lot of hard work which has been done before that. So what are the hard works or what is the pre-delivery consideration which should happen? Prior to delivery, it is very important to identify perinatal risk factors. It's important to ensure that we arrange appropriate team members so that we can assign roles. Once people are arranged, a pre-delivery briefing is very important because it helps in assigning roles as well as responsibilities prior to delivery only. It's not like once the baby is delivered, oh, who is taking care of the airway, who is taking care of the circulation. So this is very important. It improves not only the communication, but it also improves the efficacy among the team members. Before the delivery even happens, also ensure that there is an optimal communication between an obstetrician and the newborn care provider. Unfortunately, a lot of time this point is like not looked into much. So please ensure that even before the baby is delivered, ask few basic things to the obstetrician. You are mentally prepared about it. Among few things which actually should be asked before a delivery happens is there are four pre-birth questions to be asked. One is what is the expected gestational age? Accordingly, you might need some more help. Or what is the amniotic fluid like? Is the amniotic fluid clear or is it a meconium stain or there is any bleeding PV? Are there any additional risk factors? We all know the risk factors can be either antenatal or it can be perinatal. Like for a mother who is already known pre-eclamptic or is already oligohydramnios, we know that these are antenatal risk factors. If in the perinatal period there is sudden fetal bradycardia or there is abruptio, these are perinatal risk factors. Once we have asked about these three questions, we have to mention or we have to see what we can do about the umbilical cord. So that is known as the umbilical cord management. We'll talk about it in the next slide. So these four pre-birth questions are very important before you actually are ready for delivery. Once this is done, as a team, it is important to do an equipment checklist. So to have that, it is better to have a standardized equipment checklist. Most of the hospitals will be having it, but the NRP, the NNF IAP NRP provides a equipment checklist, which we can see on the left-hand side. I'm not going through much about it, but this is the standard checklist which should be available, and accordingly, all the equipment should be available for resuscitation. So going ahead about umbilical cord management. So we all know that why in recent times umbilical cord management or there is so much emphasis on the umbilical cord management. It is important to put this pre-birth question because it helps in facilitating communication and coordination between the obstetric team and the pediatrician. There's a lot of literature which has told the benefits of delayed cord clamping in preterm as well as term infants. So what does the NRP or ACOG guidelines say? The NRP and ACOG guideline recommend that at least 30 to 60 seconds of delayed cord clamping should be done in vigorous newborn babies who do not require immediate resuscitation. Also, DCC is not recommended when placental circulation is impaired, such as in cases of abruption placenta or cord avulsion. Now, when we say this, what are the benefits which a baby usually have? There are benefits in term babies as well as preterm babies. In term babies, it can increase the hemoglobin concentration in the first 24 hours. It can increase ferritin concentration in the first 3 to 6 months. In a preterm baby, very important, it will bring down the likelihood of blood transfusions. It will improve the circulation and blood volume in the initial phase, thereby reducing the need of inotropes. And most importantly, it will decrease the risk of IVH. So there is so much of literature which supports the importance of delayed cord clamping. Then a lot of people say, oh, probably we don't do delayed cord clamping, we will do umbilical cord milking. So what are the guidelines or what is the latest ILCOR update about it? So when I say ILCOR is International Liaison Committee on Resuscitation. ILCOR recommends that umbilical cord milking may be reasonable in cases where DCC cannot be performed for late preterm and term infants. Umbilical cord milking can also be reasonable when DCC cannot be performed in preterm infants born between 28 to 34 weeks who do not require resuscitation. But it is not recommended for preterm infants aged less than 28 weeks gestation due to increased risk of IVH. See, at the end of the day, whenever you are like just doing a umbilical cord milking, you're pushing too much of volume into the baby. That is approximately sometimes 30 to 60 ml of blood volume also. So that can lead to sudden and because the preterm baby's brain doesn't have auto-regulation, so it can increase the chances of IVH. Now, when we say umbilical cord milking, what does umbilical cord milking actually mean? Umbilical cord milking is a technique that involves, please note this important keywords. It is gently squeezing, clamping of the cord. It is an in times within a period of 20 seconds. Okay, so umbilical cord milking should be gently squeezing the intact umbilical cord towards the newborn in 2 to 4 times within 20 seconds of time. So you can see this. I have a thread, so there should the umbilical. I don't know whether it is visible, but if the umbilical cord is there at the placental end, quickly pulls it down, does this once, then the other provider leaves the umbilical cord for some time so that there is some refilling, again holds it, again pulls it down. This is to be done 2 to 4 times, which helps in ensuring that the extra volume of blood comes over. It helps in respiratory stimulation, it restores the left ventricular preload, and it causes improvement into the pulmonary and circulatory cerebral blood flow. Going ahead with the rapid evaluation and initial steps. So once the baby is born, this is very important. There should be a rapid evaluation about after the baby is born. Assess if the baby is actually looking appropriate for gestation, whether it is like small for gestation or it is very large for gestation, has a good tone or not, is the baby breathing or crying. If the answers to all these things says yes, the baby can remain with the birthing person and we can do a routine care and ongoing evaluation. If the after the rapid evaluation, if the baby is not crying or the tone is not, the initial steps of NRP algorithm should be followed, which includes to warm the baby, position the airway in neutral or side position, and gently suction. Again, you please remember this only if it is needed. So gently suction the mouth and nose if needed. Routine suctioning is not recommended because there is no benefit in babies who are crying and vigorous, especially in term babies. Gentle suction you should be doing only when the secretions are obstructing the airway, if the baby is having difficulty clearing the secretion, or if the newborn is apneic and as provider we are anticipating to start PPV. In this situation, we should do a gentle suction. What happens when you do deep suction? Whenever you do a deep suction, it injures the tissue, as well as sometimes it can cause a vagal response, which indirectly leads to bradycardia and apnea. So sometimes poking too much inside is not recommended. A lot of questions do come regarding meconium stained liquor, whether it should be done or not. Remember one thing, in both vigorous and non-vigorous infants, routine intubation and tracheal suctioning immediately after birth are not recommended at all. If you are encountering a preterm baby less than 32 weeks and very low birth weight baby, other additional things which you have to look after is thermoregulation, because there is high chances of hypothermia in such babies. What do you do in this scenario? Either setting up the temperature of the room, using thermal mattress, polythene bags or wraps, placing hat on the infant's head, using warm and humidified gases wherever needed, using some controlled radiant warmer, and if you have to shift this baby to the NICU, using only pre-warm transport incubators. This is very much important to be done. Okay, so these are the things. Going ahead, once we have done with the initial assessment, it is important to target the airway, breathing, oxygen, and ventilation. So if after the initial steps of resuscitation, you should always ask if is the baby apneic or gasping and what is the heart rate. If the baby is apneic and gasping and heart rate is less than 100 beats per minute, then please initiate PPV. When you are administering PPV, remember these 3 points. The breath should be given at a rate of 40 to 60. start PIP at 20 to 25 centimeters of water and PEEP at 5. Place pulse ox on the right hand so that you know about the preductal saturation. Remember, it is in that hassle or chaos. Many times you put SATS probe on the lower limb. It always will detect the postductal saturation and it will be lower than your preductal saturation. So placing pulse ox on right hand is very important. Use targeted oxygen saturation table to adjust and maintain oxygen level, because at the end of the day, oxygen is a medication. It will have its own potential side effects. So these are the oxygen target saturation table which is available in the algorithm, and accordingly we have to target our saturations. Okay, when initiating PPV, resuscitation should start in 21% oxygen in term infants, and if the baby is less than 35 weeks, you can start anywhere between 21 to 30% of oxygen. Going ahead, once you have started PPV, as I mentioned, PPV can be provided by either a self-inflating bag, a flow inflating bag, or a T-piece resuscitator. We'll talk about these three things, how they work. But once you have started PPV, the most important indicator of a successful PPV is not chest rise. Remember, it is rising heart rate. So the heart rate should go up. If the chest is not moving and the heart rate is not rising, then we have to do ventilation corrective steps to ensure that the effective ventilation is delivered. A mnemonic to remember in ventilation corrective steps is MR. We all are aware about it, but just going through it again. MR means M suggests for adjust mask to assure includes suctioning. O is opening the mouth slightly, and P is increasing pressure, and A is considering an alternate airway. So MR SOPA is very important. In babies who are late preterm and term infants, if intubation is not possible or successful, then SGA, that supraglottic airway, or LMAs can be used, laryngeal mask airways. In babies who are otherwise having spontaneous respiratory effort and the heart rate is also appropriate, but there is labored breathing, CPAP should be administered with a PEEP of 5 and starting oxygen concentration 21%, which can be titrated as per the age of the child. As I was mentioning, there are three ways by which you can give PPV: self-inflating bag, T-piece resuscitator, flow inflating bag. We all are aware about it, have seen all these things, just quickly going through it. The thing is, the upper bag is commonly used. It is anywhere between 240 to 500 ml capacity bag. T-piece resuscitator, it needs a gas source. The good part about it is you can control the PIP as well as the PEEP. You know exactly how much PIP you are giving, how much PEEP you are giving. You can give PEEP also, which you can't give a self-inflating bag. Flow inflating bag, it is less commonly used. Again, it also needs gas source, and limitations are definitely more with self-inflating flow inflating bag. While we are talking about the devices, remember appropriate mask size is very important. When I say appropriate mask size, the mask should cover the chin, mouth, and nose, but it should not cover the eyes. Sorry, I mentioned nose, but not cover the eyes for sure. Going for ahead, once we have done PPV, if there is persistent heart rate which is below 100, cardiac monitoring there, because once you have got to a stage where you are needing alternative airway, it is important to monitor the heart rate of the child by having a ECG monitoring. I know a lot of setups and places this can be a major limitation because cost as well as resources. These are the two major factors. But still, in the guideline, it is recommended that electronic cardiac monitoring should happen once the child is on alternate airway. Once we have done 30 seconds of positive pressure ventilation, that is inflating the lungs, means there is the chest rise is there. And if the heart rate is still below 60, then chest compression is indicated. The chest compression should be in a coordinated way with the ventilation. When I say coordinated, it means it says 3 compressions to 1 breath at the rate of 90 to 30 breath per minute. there are two techniques. We know the two thumb technique and the two finger technique. The two thumb technique is only preferable over the two finger technique, and now it is completely absolute to use the two finger technique. There are a lot of colleagues who still use the two finger technique, but it doesn't give the effective chest compression, and it doesn't help in increasing the cardiac output. Once you have started with chest compression, coordinated chest compression, assess heart rate every 60 seconds. If the heart rate increases above 60, please stop chest compression. If the heart rate remains below 60, in this situation, vascular access and adrenaline administration are needed. This has to be given either the umbilical venous catheter or intraosseous route. We know if we have to give this medication, epinephrine is the drug of choice. Indication I have already told. If there is persistent heart rate below 60, after at least 30 seconds of PPV that inflates the lungs and 60 seconds of coordinated chest compression with PPV with 100% oxygen, then you use adrenaline. In India, we get 1 in 1000, which we have to dilute with 9 ml of normal saline to make it 1 in 10,000. The dose is 0.2 ml per kg for IV or IO, followed by an 3 ml saline flush. And while you are preparing for getting an umbilical line, because it is not going to happen that you are just like, okay, I want to give medications, you immediately are there with an umbilical line. At that time, you can give endotracheal adrenaline, but at a dose of 1 ml per kg. This dose can be repeated every 3 to 5 minutes if the heart rate is persistently below 60. If the child is still not responding or the newborn baby is still not responding, please consider hypovolemia, which can happen in cord prolapse or abruptio, or there can also be tension pneumothorax while we are doing so many things simultaneously. Then the question comes about, okay, when do we stop actually resuscitation? What does the 8th edition NRP say? It basically extends the time frame of resuscitation to 10 to 20 minutes after the stoppage of heart rate. So now you have to at least continue for 10 to 20 minutes from the stoppage of heart rate. Why? Because the recent systematic review reported that there was survival among infants at or beyond 10 minutes of resuscitation without moderate or severe neurodevelopment impairment. So that's the reason why it is now suggesting 10 to 20 minutes. So with this, I have covered whatever was the practical aspect in the journal. But as we talk and as we go through, in October 25, the American Academy of Pediatrics and the AHA released the 9th edition of NRP. It predominantly is same to the previous 8th edition of NRP. But as I was talking about the recent advances, I thought like I would touch base on the major changes which have happened. So the changes which are there in the 8th edition and the 9th edition are, in the 9th edition, birth and initiate cord management plan has been added in the action. If you see in previously antenatal counseling, team briefing and equipment check was there, followed by birth. But here they have added birth, after birth, initiate cord management plan they have specifically added, just to emphasize the importance why delayed cord clamping should be done, and so that at least people start thinking about it. Okay. They have also removed suction from the initial steps of resuscitation, which we had already discussed that it is clearly mentioned that suction if needed. In the newer one, they have said clear airway if needed. Okay, so the word about suction is now being taken out in the 9th edition. Terminologies like PPV, positive pressure ventilation, is now being changed. If you look into the new box in the 9th edition, they now refer it to as ventilation. Regarding cord clamping, previously it was said 30 to 60 seconds. Now it is clearly said that you have to defer cord clamping for 60 seconds. Nothing like a time frame of 30 to 60 seconds. 60 seconds you have to do. Umbilical cord milking, it still remains the same for term and late preterm who remain non-vigorous despite stimulation. Milking intact cord may be a reasonable alternative. Those who are non-vigorous between 28 to 34 weeks, there is not even enough evidence to recommend. And intact cord, umbilical cord milking is definitely not recommended in preterm babies who are born below 28 weeks. Going to targeted oxygen saturations, they have now removed the 1 minute target because it is practically not feasible. The initial 1 minute, obviously, you take to do the initial steps, you have to do a rapid evaluation, then you have to do the initial steps, and then you apply the pulse ox. So now in the newer edition, the target oxygen saturation starts from 2 minutes. Also, they have like went ahead and broken down the oxygen concentration to start, like the starting oxygen concentration. So previously it was like only into two groups, like more than 35 weeks or less than 35 weeks. Now in the newer edition, it is like more than 35 weeks you start at 21%, 32 to 34 weeks you can start at 21 to 30, and less than 32 weeks you can start at 30. Other minute changes which are there. Previously, the ventilation rate was 40 to 60, where we used to say breathe 2-3, breathe 2-3, breathe 2-3. So now they have like increased it to ventilation rate of 30 to 60. Initial peak inflation PIP, the suggested initial PIP now is 25. Acceptable for babies who are above 32 weeks, you can go up to 30, and below 32 weeks, 20 to 25. Previously, the range was 20 to 25. So these are like all minor changes which have been done. Even for the ventilation corrective steps, initially it was like you perform M and R, then you give 5 breaths, then you see S and O, and then go ahead. But now, based on your assessment, you may choose whatever steps you would like to do, because that is more helpful. You know that, okay, the mask and all those things is correct, but the child actually needs suctioning. So you can directly go to the suctioning and you can prioritize the order in which you would like to perform them. So this is there. And last but not least, the LMA still plays an important role. You can start ventilation with a face mask or LMA. And the endotracheal tube sizes have been changed. Now the table has been adjusted according to the recommendation for newborns below 800 grams. So previously it was like 1 kg. So babies who are like less than 800 grams, 2.5 size ET tube is being used. And from 800 to 1200 gram, you can use a 2.5 size tube. From 1200 to 2200, you can use a 3 size ET tube. And about 2.2, you can use a 3.5. So previously there was only 3 categories: less than 1 kg, 1 to 2 kg, and more than 2 kg. Now it has been divided into 4 categories of less than 800 grams, 800 to 1.2, 1.2 to 2.2, and more than 2.2. As we all speak about, those who are like interested and would like to go ahead and read, Dr. Somsekhar Nimbalkar sir recently, like in actually 26th of January only, they published this article, which was published in Indian Pediatrics, the 2025 ILCOR neonatal life support Koster guidelines, that is the consensus on science with treatment recommendation, the key updates. So it has nicely like told about the background, the summary of changes, as well as it briefs into the changes which have been done. So people who are interested can go ahead and read about it. With this, I would like to end my talk with a few take-home messages. The most important is the NRP provides basically an evidence-based clinical guidelines and an algorithm for neonatal resuscitation, with a goal of having a trained neonatal provider for every delivery. It recognizes and evaluates each hospital's unique array of resources, workforce availability, and physical spaces. There is a lot of emerging areas of science which should be monitored for further guidance on optimal umbilical cord management, ideal oxygen concentration, risk and benefits of CPAP, and use of supraglottic airway. Teaching plays an important role, so simulation and telesimulation can improve technical and team performance and should be considered to enhance education, training, and team building. And we all know, at the end of the day, successful teamwork and effective communication with other members of the healthcare team will give the best result to all our newborn babies. Thank you so much.
Thank you so much, Tejas sir. Rightly said, teamwork and teaching the right procedure is very important, and you have presented the article very nicely. And we didn't interfere in between, even though the time exceeded. But we appreciate that you have taken special efforts to update us with the new 2025 NRP guidelines also. Thank you so much, sir. So now I invite our expert, Dr. Swapnil sir, for his expertise comments. Over to you, sir.
Thank you, Dr. Neha. I hope I am audible.
Yes, sir.
So it was very well presented, and the thing is, he presented in very detailed manner. Mostly, generally, it is always admirable to have a team approach in recitations, but practically speaking, in our country, we work in remote places. We go in some kind of private labor rooms and all this kind of stuff. So sometimes we don't get team. So all things what we haven't discussed has to be planned individually. Now the important point with after this presentation is that every delivery, the gynecologist has to be taken into consideration that delayed cord clamping karna hai. The thing is that mothers, they are not beneficial of this thing. It's the baby, and the gynecologists, they are always in hurry after the delivery. They are always in hurry just to cut the cord as soon as possible because they want to shift the baby. The ultimate take home point is we have to be inside the labor room, in the OT table, in the OT room, so that we have to stop them not to cut the cord. It's okay, baby is crying, baby is okay, baby is fine. Let them assure. Then only this thing practice can be done. Secondly, if a baby is not crying, sometimes it's like we have seen that there is overstimulation. बहुत मतलब teach बहुत ज़्यादा they stimulate, then they rub the back. That is actually not useful. In one or two stroke, if a baby is not crying, we have to move to second step. Don't have to wait till more stimulation is required. Third important point, there is no benefit of giving extra dose of adrenaline. If you give extra dose of adrenaline, though if a baby is recovered from the whatever the heart rate being low, but the return of spontaneous circulation, it again is going to take a longer time. So that is not useful giving extra dose of adrenaline. That means not going beyond 0.2 in a single shot. And lastly, it has to be always a discussion ki what has happened good in this recitation or something which we have missed, and discussion with the team member is very essential. That is debriefing is also essential. If there are any questions, we can take.
Yes, sir. After the second presentation, we will take the questions. Now I invite Dr. Samruddhi to present her article. Oh, Dr. Samruddhi, please start sharing your slides and you can start. She will be presenting on accuracy of home blood pressure monitoring in youth, a systemic review and meta-analysis. Over to you, Dr. Samruddhi.
Am I audible?
Yes. You can start.
Good evening to all the respected members present in this meeting. I thank Maharashtra IIP for giving me this opportunity to present this journal in such an insightful session. So the article that has been given to me is Accuracy of Home Blood Pressure Monitoring in Youth, which was published, which is a systematic review and meta-analysis published in the renowned Journal of Pediatrics, volume 284 in September 2025. So, pediatric hypertension affects 4% of children worldwide. Clinical or office BP screening is recommended yearly from 3 years of age, but it has accuracy limitations because of the prevalence of white coat hypertension, which is normal out of office BP and high clinical BP, which can lead to overdiagnosis and unnecessary follow-ups. There's also issue of mass hypertension, which is normal clinical BP and high out of office BP, which can cause underdiagnosis and mistreatment. So, ambulatory blood pressure monitoring is currently the reference standard for confirming pediatric hypertension, but it has a plethora of limitations. First of all, it is not widely available in pediatric primary care and typically requires referral to subspecialists, which is not always feasible. It is poorly tolerated for full 24 hours in pediatric population specifically, and it limits the child's activities. It requires time to obtain and involves expensive hardware and software which might not be available in every setting. Home blood pressure monitoring, in contrast, involves BP being measured multiple times per day over several days. And because of convenience and ease of use of home blood pressure monitoring and self monitoring, factors such as white coat hypertension, it is a preferable alternative, although additional data is required for making it a standard reference for confirming pediatric hypertension. So the population which was taken in this study were children and adolescents for less than 18 years of age who underwent both home blood pressure monitoring and ambulatory blood pressure monitoring. The intervention was home blood pressure monitoring, which was compared with 24-hour ambulatory blood pressure monitoring. Outcome was measured in terms of continuous differences, which was the mean difference between home blood pressure monitoring and ambulatory blood pressure monitoring, and in terms of categorical accuracy, in terms of sensitivity, specificity, and kappa. The time frame for this analysis was from the inception of the database to November 13, 2024. So at the end of the study, the clinical question was, can home blood pressure monitoring reliably diagnose ambulatory hypertension and related phenotype in youth and its comparative accuracy and benefit as compared to ambulatory blood pressure monitoring? The study type is systematic review and meta-analysis, and the databases searched were Medline, Embase, Web of Science, and Cochrane Library. Screening was done independently by 2 reviewers, and full text was assessed for final inclusion. The data extracted was in terms of study setting, population involved in the studies, devices used, home blood pressure monitoring and ambulatory blood pressure monitoring schedules, which varied widely between all the studies, mean BP values, and hypertension threshold. Quality assessment was done by Quality Assessment of Diagnostic Accuracy Studies 2 tool. This is the PRISMA flowchart of the study. According to this, the record identified from the databases were totally 4,321 in number. And after removing the duplicate records, a total of 2,966 abstracts were screened. After excluding the records through the screening process, a total of 196 articles were assessed for eligibility. From that, 170 were excluded because 72 had wrong study design, 36 were included adult population, 23 had no comparison with ambulatory blood pressure monitoring, 16 were conference abstracts of included articles, 13 included no home blood pressure monitoring, 9 were conference abstracts with inadequate information, and one was a duplicate. So at the end, 26 studies were included in this review. Conclusion criteria is children and adolescents less than or equal to 18 years, and prospective and retrospective observational studies were included. Studies comparing home blood pressure monitoring versus ambulatory blood pressure monitoring on either a continuous scale, that is the mean blood pressure or mean difference between these two values, and categorical scale, that is hypertensive or normal blood pressure, sensitivity or specificity, and kappa, etc. were measured. And conference abstracts were included only if enough required data was available. Exclusion criteria included excluding the studies which involved adult population or mixed adult or children without separate data for pediatric population. Studies which had no comparison with ambulatory blood pressure monitoring were also excluded, and duplicate or overlapping cohorts were also excluded from this analysis. Statistical analysis, continuous outcomes, primary comparisons, and nocturnal analysis was measured. Missing data handling was done through correlation coefficient between both the BPs imputed as R equals to 0.7 when it was not reported. Meta-analysis approach was done by hierarchical random effects with robust variance estimation to amount for clustered centers. Categorical outcomes via sensitivity or specificity, and agreement was reported as ranges due to heterogeneity because of no pooling. So this is a chart showing risk of bias and applicability concern. The A graph shows all the included studies and the high risk, unclear risk, or low risk in terms of 7 parameters. And the B graph shows summarized high, unclear, and low risk bias across all the included studies. So according to this, nearly all the studies, that is 24 out of 26 studies, had low risk of bias around the conduct and interpretation of the index test. 12 studies had unclear or high applicability concerns around the definition of ambulatory hypertension. 10 studies had unclear or high risk of bias related to patient flow due to lack of information about the timing of home blood pressure monitoring or ambulatory blood pressure monitoring. So, coming to the results of the study, this is a forest plot which shows the paired mean difference between the systolic home blood pressure and systolic ambulatory blood pressure across multiple studies. Each square here represents the effect estimate of an individual study, and the horizontal line indicates its 95% confidence interval. The vertical line at 0 represents no difference between the home blood pressure and ambulatory blood pressure. Most study estimates lie to the left of the 0 line in this graph, indicating low systolic home blood pressure values as compared to the ambulatory blood pressure. The diamond at the bottom represents the pooled estimate effect, which is minus 6.4 mm of Hg, suggesting overall low home blood pressure readings in these studies. The I-square statistic value of 98% indicates very high heterogeneity, showing substantial variability amongst these included studies. This graph also shows that most of the study estimates lie to the left of the 0 line, indicating low diastolic home blood pressure as compared to ambulatory blood pressure. The pooled effect estimate here is minus 3.3 mm Hg, showing an overall low home blood pressure reading. I-square statistic again here is 94%, indicating high heterogeneity amongst all of these studies. The graph here shows that both negative and positive estimates are present in all the individual studies, indicating variable direction of difference across these studies. The diamond at the bottom, that is the pooled estimate, is minus 1.3 mm of Hg, lying close to the line of no effect. I-square value here again is 94%, indicating high heterogeneity. This graph also shows that most of the study estimates lie to the right of the 0 line, indicating high diastolic home blood pressure values as compared to ambulatory blood pressure. The pooled estimate here is plus 2 mmHg, lying close to the line of no effect. I-square value here is 88%, indicating high heterogeneity, suggesting considerable variability amongst all of these studies. So, after looking at the result, overall, we can say that home blood pressure readings were consistently lower than ambulatory blood pressure readings during the day in children and adolescents. Home blood pressure showed only moderate ability to identify true ambulatory hypertension, meaning a significant proportion of hypertensive children would be missed if home blood pressure was used alone. The specificity of home blood pressure was good, so when home blood pressure was high, it usually reflected true hypertension. The home blood pressure performed well in identifying white coat hypertension, showing good agreement with ambulatory monitoring. Also, the detection of masked hypertension was poor, indicating that normal home blood pressure does not reliably exclude elevated ambulatory blood pressure. There was limited data on nocturnal home BP monitoring, showing that nighttime home readings tended to be slightly higher than ambulatory nighttime values, with only moderate agreement. And across all these studies, overall agreement between home blood pressure and ambulatory blood pressure was moderate, and all of the results varied due to differences in the protocols and thresholds which were taken across all of these studies. The critical analysis includes the strengths, which are comprehensive database searching via Prisma reporting and Prospero registration for transparency. A robust variance estimate was done, which helped account for a clustering because many studies were from the same center or region. The risk of bias was generally low for index text conduct, but applicability concerns were there for patient selection. Heterogeneity in home blood pressure monitoring schedules and thresholds limits the direct comparison and reduces confidence in pooled conclusions. Most of the studies use device validated in adults, raising concerns about the measurement accuracy in pediatric cuff sizes. Categorical diagnostic outcomes could not be pooled, so conclusions here rely on ranges rather than on combined estimates. This analysis had certain limitations. That is, different hypertension thresholds were taken for home blood pressure monitoring and ambulatory blood pressure monitoring across all of these studies. The home blood pressure monitoring protocols varied. That is, the number of days measured, frequency of taking the blood pressure, duplicate versus triplicate readings, and validation criteria were different across different studies. The sequence and timing between home blood pressure monitoring and ambulatory blood pressure monitoring was not often randomized, and sometimes they were not reported. Potential order effect may occur if BP readings are systematically lower when the second device is used later. Nocturnal home blood pressure monitoring evidence is limited only to 2 studies. This makes conclusion about nighttime diagnosis uncertain in this meta-analysis. Generalizability is also limited because many cohorts were from specialty hypertension clinics rather than the general population. So at the end, when the ambulatory blood pressure monitoring is not available, we can say that home blood pressure monitoring can then be a practical alternative for us. This home blood pressure monitoring shows good specificity and it may be helpful to confirm hypertension when the readings are consistently elevated in clinical settings. Home blood pressure monitoring performs well for identifying white coat hypertension but poorly for detecting masked hypertension. Its accuracy in youth is not sufficient to replace ambulatory blood pressure as a single diagnostic test for pediatric hypertension. So, future studies should be made to standardize pediatric home blood pressure monitoring protocols and validate devices in children and refine the thresholds for hypertension. These are the references for the study. Thank you.
So thank you, Dr. Samruddhi. You have presented the article very well and giving the general pediatrician the message when ABPM is not available, HBPM may be a practical alternative, but HBPM accuracy in youth is not sufficient to replace ABPM as a single diagnostic test for pediatric hypertension. So now I invite Dr. Anand sir for the expertise comments. Over to you, sir.
Thank you, Dr. Neha. Am I audible?
Yes, sir.
Yeah, thank you once. First of all, I'd like to thank MAHA-IAP President sir and Raigad IAP President and MAHA-IAP Secretary for giving me this opportunity to learn with, I would like to say I am still learning. So to learn with these PG students and experts and very well presented Samruddhi. She has almost, before this presentation, I had taken out many points. So most of the points have been covered by her. All the limitations, what are the studies requirements, and in which setup the study has been done. She has most of the points she has already discussed. So I'd like to just draw few attention towards pediatric hypertension. It is one of the critical yet underdiagnosed condition in the pediatric age group. It is under recognized as well as underdiagnosed because most of the time office BP is not taken as a routine practice still in our say office setup unless and until it is some signs or symptoms are warranted. But nowadays with this obesity epidemic which is coming into and sedentary lifestyle, more screen timing in the children, these other complications of elevated BP is coming the cause of the hypertension as essential or primary hypertension is on rise now. So we need to be little bit careful while in our day-to-day OPD. We must take blood. We must try and train ourselves and get into a habit of taking blood pressure of each and every child above the age of 3 years because that is the recommendation. Below 3 years, of course, if it is symptomatic or some other risk factors like low birth weight and prematurity is there, then we'll take it. Otherwise, more than 3 years, we should make it a routine practice to take blood pressure, just like taking weight of the child. So that is one thing. Then the both immediate and long-term health outcomes are very much related with this elevated hypertension. Now the 2017 guidelines, American Academy of Guidelines, they have divided this into the 4 categories. There is a phenotypic classification into normal BP, white coat, masked hypertension and ambulatory hypertension. So normal whatever BP we get, even if it is elevated BP, it is also very much important. Sometimes we feel that it is normal or on the borderline, but still we should approach it towards take it very seriously and try and find out the cause for it. Another thing is there are very much many modifiable risk factors in childhood, just like in adults they are coming up, like BMI, systolic blood pressure, cholesterol, triglycerides, and youth smoking. So all these modifiable risk factors should be taken into consideration so that we can apply our non-pharmacological measures and other measures so as to curb the hypertension initially only and to prevent its long-term side effects. Then again, another thing I would like to draw the attention is there is a definite difference between the primary versus secondary hypertension. Previously, we used to see secondary hypertension more until and unless the patient becomes symptomatic. We did not used to diagnose that hypertension. Nowadays, primary hypertension is on rise, so we must be very much aware because it is asymptomatic in stage 1. It is with insidious onset and it is incidentally detected during the routine medical checkups. And there is an increased prevalence of more than 50% of cases of hypertension with obesity epidemic, and there are modifiable risk factors. So all these things taking into detail, we must screen. Of course, secondary hypertension in newborn period, it may present with all symptoms like coarctation of aorta and mid-aortic syndrome and all those congenital heart diseases. They are very much amenable to detection, as well as renal diseases. They are also amenable to detection. So early identification, start institution of the early treatment, modify the risk factors which are there, and other thing is correct measurement of the blood pressure is also required. In pediatric, we don't have validated cuff sizes and validated BP instrument, because in according to there is one I forgot the name of that organization. It is Academy for Validation of Instrumentation. They gave that more than 30 to 35 children should be more than 35 instruments. 35 children should be screened with the instrument before validating it. So it is not done. It is done only in adults. Now till now we don't have any home BP or ambulatory BP validated instruments available with us. So that is one of the drawback. So we should have them and we should start taking our measurements by that. Again, that there is a difference between oscillometric machines and auscultatory BP measurement, because most of the home BP instruments, they take the reading by oscillometric methods, but elevated BP needs to be confirmed by repeating the readings with auscultatory BP measurement, because auscultatory BP measurement, it directly correlates with the future risk of cardiovascular and renal diseases in the adulthood. So that is very much required. Again, correct BP sizes, that the bladder of the BP cuff should cover 80 to 100% of the circumference of the arm, with 40% width should be covered. The child should be rested for 5 minutes in a sitting position with legs hanging and arm resting, and then the BP should be taken at a correct midpoint of the mid-arm. So all these things should be taken. So correct BP measurement is one of the requirement, I would say, for diagnosing. And again, elevated BP defined as more than 3 readings taken on 3 separate occasions, elevated readings. So if you take 1 reading at a time and that is elevated, you have to repeat 2 readings and take the average of that reading as a final reading. So this is 1 occasion, and 3 separate clinic office BP occasions you must take them to document that the BP is elevated, and then only you can label it as a elevated or this high BP or a stage 1 or stage 2 blood pressure. Again, this recognizing the potential for target organ damage is very much required, that is target organ injury, and we have now different we have different now indices for that, like LVH risk, that is left ventricular mass index, arterial stiffness measured by pulse wave velocity, carotid intima media thickness, and retinopathy and albuminuria compared with normotensive children. So all these should be also be tried, all these new things. There is one novel technique also combining ambulatory BP with the to avoid the white coat hypertension. It is called as AOBPM, or automated office BP measurement, in which the instrument takes the blood pressure on its own in a separate room unattended by anyone, so that there is no stress on the patient and it mitigates the effect of white coat effect. So this you can combine this with nocturnal home BP monitoring to improve the diagnosis of hypertension without ambulatory blood pressure monitoring. So that is also one of the added advantage what we can try, but then the instrument is still not available with us. So with this, I would like to say that it is one of the morbidity factor, one of the disease which leads to lot of morbidity and mortality in the childhood. And as like we are experiencing an epidemic, or I would say endemicity of for diabetes in India, just like that in future we will experience the hypertension epidemic in children also in India. So we must try and stop that epidemic. Thank you very much.
Thank you, sir, for very elaborately explaining us. So I would like to, Dr. Swapnil and Dr. Tejas, anyone can reply. There are questions in the chat box. Dr. Sachin sir has asked, is there any advantage of nasal high flow in initial resuscitation?
As far as I understand, there are not much studies which have been done.
Sir, your voice is little low.
So as far as I have I have looked into the data before, but not much studies on it. And the whole purpose is like giving that initial peep and increasing the functional resilience. So, Dr. Kapil, if he has any more information about it, but I don't think so much evidence is there.
Okay. We have one more question from Dr. Mahesh Sulakshani sir. How reliable is pulse oximetry in first minute of neonatal resuscitation?
So in first minute, obviously there are challenges with having the pulse ox, because the major challenge with having pulse ox in such situation will be it is slow to pick up. Usually it takes time to pick up. Even if you have attached, it takes 20 seconds to pick up or so. And the initial perfusion in such kids like the newborn babies will always be poor. We are into this thing. So early low saturation is physiological and it is expected. So heart rate is given more importance in the initial phase. So that's why when we look at the algorithm, it says about checking the heart rate of the child rather than the pulse ox in the initial first minute. The main reason the pulse ox is being used is it is used to guide oxygen titration after the first minute. Like once you have like gone into the later phase of your resuscitation, to help in not uh, giving too much of oxygen to the baby or causing oxygen free radical injury is more important. So it is the whole purpose into later thing is to titrate the oxygen.
Okay. Sir, adding to this, we have one more question. Why 10-20 minutes after stopping of heart? Why not fixed interval? This is asked by Dr. Vasant Dhamal, sir.
I think it is now 20 minutes only. It is like at because see, if you look at it, ma'am, it will be like once you have started resuscitation and once you have reached to a stage where you are actually giving adrenaline, I'm sure like in the best of the best facility and best of the best centers also, so anywhere between 8 to 9 minutes will be elapsed where you are like actually giving first dose of adrenaline. So from there, it will be recommended like at least you have given 2 to 3 doses and then take a call on it.
Okay. Dr. Anand, sir, we have a question that
Yeah.
at what age in Indian child BP is 120/80 mmHg and about the size of cuff and age of child? Please elaborate.
Yeah, according to 2017 American Academy of Pediatrics Clinical Practice Guidelines, children aged 1 years to less than 13 years, they are given systolic and diastolic BP should be less than 90th percentile. They don't mention about how much millimeter of mercury for 1 to less than 13 years. and more than 13 years they give systolic BP should be less than 120 and diastolic should be less than 80 millimeters. So that is more than 13 years they have given 120 80 should be normal, and it should be less than that. That is a normal BP.
Okay. And Dr. Shrikant sir has asked appropriate validated BP apparatus with pediatric cuff. Please suggest.
Actually, as I have told, the pediatric cuff size, as far as size is concerned, they have given guidelines that it should cover 80 to 100% length of the mid-arm circumference plus 40% width of the that cuff should be there. But for neonates, they have given the ratio of 0.45 to 0.7 of width to mid-arm circumference for that bladder cuff. So accordingly, you should choose the appropriate size cuff. For the validation, as far as the validation of the BP machines are concerned, there are different BP machines are available for home BP and ambulatory BP for adults, and they have been validated for adult, but not for pediatric.
Right.
Yeah.
So questions in the chat box we have already taken. Dr. Neeman Mohanty sir, I would like to request, sir, your
No,
sir, you
not
want to add something? Yes, sir. Please,
no,
sir.
not much comment, because today's the experts comments have been excellent. They have, actually, the whole purpose was to send a message to the community, our practicing pediatrics in the rural areas, that we do not have those ambulatory BP measurement instruments, and home care BP measurement will be a practical idea. Then it is very near to the ambulatory blood pressure monitoring also. So we are all convinced that we should also encourage our parents at home, because once you have taken BP is showing little higher in your clinic, you cannot label the child as a hypertensive. As Dr. Anant already emphasized, at least 3 readings on different time intervals will be required. So that's why the home care BP monitoring in the own environment or white coat hypertension is unlikely. It should be emphasized. We should convince our practitioners that parents should be encouraged to take repeated BP monitoring in their own setting and take a record, bring it the record at least after a week to see whether what is the minimum blood pressure they have recorded. That is the correct message to what intended. This neonatal resuscitation, both are experts, both are neonatologists, so I have no comments. One is the expert is also from PGI Chandigarh, my parent institute. So they have done very well. उसमें कुछ बोलना नहीं, because the article we came to our hand is 8th edition. 9th edition we may not discuss because it's already almost similar. There is no much change. So we should rather, he has already discussed, Dr. Tejas, that is very kind of him. He has brought those things and compared before us. So I think nothing more to add. So your neonatal resuscitation programs, this include now 9th edition recommendations stateway. Another thing I want to add, here in MGM, we have tried this milking of the cord blood. Here in one study, we have used milking rather than delaying, because see, the practical difficulties, the obstetrician friends, they are reluctant to wait, particularly in the corporate settings. They want to go for another delivery or go to another table. So they are in a hurry, and they want to shift the responsibility of the pediatrician. The baby is yours. They will hand over. So they cut the umbilical cord. See, the recommendation in obstetrics books, if you see textbooks, it is recommended from 1951, 52. Old textbooks, I have looked into it. It's already recommended there also. But we guys don't practice it. So first thing is, we should take our best friends, the obstetricians, to practice it. With that, only we get their help, we can't achieve our goal. That's my idea. And we have done 200 babies milking and 200 babies delaying the cord clamping. We found the results are similar. What astonishing result, which is not reported, we got it. You see that physiological anemia was not detected in the babies where this milking was done. Even the little dip of hemoglobin doesn't occur at the 3 months or so. One. Number two, ferritin, definitely it is higher. And we have followed up these babies up to 1 year phase. And we have done the DDST development assessment also, all these babies. They're certainly high. And see the brain growth is more in this milking where the babies who had this cord milking. I do not know the reason. And the head circumference showing the brain growth is higher in this group. So these are the things to be interpreted. We found out further research will find out the reasons. We should practice this. Thank you.
Thank you, sir. Ganguly, sir, you want to add something? Yes, sir.
Yes, first of all, excellent presentations by both presenters and
Yes.
good practical tips by the experts. I may request everybody, if possible, to put their videos on to take a photograph of this episode. It will be better for us to recognize all the people. But I want to make some 3 or 4 maybe comments, come questions. First of all, Dr. Anand sir, is there any BP charts which we can follow and put in our OPD as per the Indian child setting? So, because there is no fixed readings which we describe as to 80, 90, but we have to follow the 90 percentile charts. So, whether it is available for the Indian children settings. And
Yeah.
and well, let me complete 2 or 3 and then
Yes.
please respond to that. It's very easy to say and very easy to discuss here, but I don't know how many of pediatricians take the BP in their consulting. So ideal, whatever we discuss here, but because you have so nicely explained, I think so you can make a small videos or what things, how to take the BP. So there are 2 types of BP also available. One is the digital one and the one is the mercury one, which one to use and not to use. And what are so how actually one should take the BP is the most important, means the demonstration of that you can make the good video which can be circulated in our, as per the Indian settings. We can go in the net and can see the things. But what we actually practically do in our Indian setting, that is much more important. That is for 2 or 3 questions for Dr. Anand sir. And I will also ask this, let him first respond and I will ask the neonatal persons. Yes, sir.
Yes, sir. A good welcome suggestion by you that everybody must start taking the blood pressure in their clinic, and we should make it a habit of doing it, and we should have some videos of correct measurement of the blood pressure, and we should encourage our juniors, PG students, UG students to take the blood pressure. We should also teach and train our parents of patients who are having elevated blood pressure or who are on follow-up for that, for taking blood pressure at home with the help of digital BP instruments, whatever are available. Of course, there are BP charts are available, sir. On this NCBI site, if you give PubMed Central site, the charts are available. They are available by the age and height percentile as per the for boys and for girls from the age of 1 year up to the age of 17 years. The charts are available, and actually I have already put up these charts since last 5 years. I have put up these charts in my PICU at our college, so that the residents can refer. I always make it a point that you take the BP, go and refer to the chart and write what is the percentile of the BP. So that is our routine practice.
Thank you, sir, for that.
Yeah.
But as we are very lazy to go and search the chart, we can
Yes.
share it. It will be
Yes.
better for us, and
Sure,
then the
sure, sir.
charts can be used. For as far as the neonatal resuscitation is concerned, I think the important message is that 1 minute hurry should be avoided. And the 1 minute में सर दूसरा किधर कॉल होगा भी नहीं पूरा, तो 1 minute रुकना चाहिए. That is most important thing. But sir, what you said now, say because we have seen the 360 release of the recently neonatal resuscitation by our CIP action plan also. I've gone through it, but then there's so much limitation. Though we say teamwork, but in practically in peripheral setup, rural setup, almost it's an individual setup. So what I want to ask from Dr. Tejas as well as the presenter who is there, presenter as well as the expert, Dr. Swapnil is there. So these guidelines are there, but whether these guidelines which works at the most of the tertiary care level, but because of I will just tell the aim with this journal journey was started was the research articles to be discussed which can be implemented in our practice of the general pediatrics practice. That was the aim of the journal journey actually when we started on the 1st of October, 1st of July 2021. So that was so looking that what I want to say or ask Dr. Tejas sir as well as Dr. Swapnil, these guidelines which are there, whether you can not modify or something you can changes which at least minimum things which can we should do at the peripheral in a rural setup. Because the reason why I'm telling is that still the rural PSC, which is just 100 meters away from my hospital, is still they are slapping the back to revive the child. So it's very foolish to tell this thing here, but it's happening in our rural Maharashtra also. So these guidelines, which minimum things which we can follow, which will save us from many litigations also. That was the perspective of asking me, Dr. Tejas.
Yes, no, very important point. And as you rightly said, like, yes, we all discuss about a lot of updates, lot of recent advances, but we all know that there is a lot of limitation with all these updates when we are working at grassroots level. But having said that, sir, until unless we make conscious effort that we are doing things will not change in the coming years, right? The whole purpose of like the Golden Minute resuscitation program and like ensuring that there are more and more trainers who have been taught. So I'm sure like every one of you are aware, and a lot of new or younger generation trainers have been trained. There's a lot of NRP sessions which are happening. So in this way, I think like the aim is to reach to more and more peripheries, and eventually when we keep bombarding about the guidelines, keep bombarding about the importance of few things, at least we will reach 50% of what is expected.
Yes.
And at the end of the day, guidelines are there to guide us so that we can
Yes.
better.
Yes.
And this is a very good platform. Of similar kind of platforms are there. So the importance of delayed cord clamping or simple things like initiation of initial steps, these are so important in bigger centers also. Delayed cord clamping, like I know how difficult sometimes it becomes to convince the organization in my setup, and we have always arguments and debates in our perinatal meet that okay, so many percentage of only babies had delayed cord clamping or so many percentage only. But yes, all of us as pediatrician will still have to take efforts and see if we can increase it. The thing is like the more we tell about the neonatal mortality and tell them the NMR, like the only way the NMR is going to come down is preventing the perinatal deaths. And for perinatal deaths, all these things are definitely going to be helpful.
Yes, sir. The point what I wanted to say actually, Dr. Tejas, I understand we should learn practicing and it comes by the experience and also we modify, we change ourselves. We don't change ourselves, but we should try to change ourselves. What I wanted to say is that because you are so much attached to the neonatology forum and everything, and now this is little bit upside, which I am telling. These guidelines when goes into public domain, they use the guidelines for the litigation against the neonatologist or the pediatrician. So there should be something, a paper from Neonatology Forum, or because you are working so much in that, so you can just suggest there should be some supportive document which can say that at least minimum this thing you are doing, it's okay, it is acceptable. The acceptable, whatever you said, not 50% whatever, but acceptable modes of the thing which will help our medical fraternity to defend in court of law. I want to tell in that perspective, sir.
Definitely, like this, the message I will also convey to like all other neonatologists and the people who are like helping in making guidelines and trying to find a perfect balance where we can use it on a regular.
Yes. Because that neonatal research is what I saw in this recently, 360 what they launched in the, when I read word by word that, It's very difficult, for, at least for me, to follow that or to implement in the rural practice. Anyway, we should try to learn. We should learn from our experts. We should learn from our presenters. How should we change ourselves and implement our practice? That is the take-home message of this episodes of the Journal Journey. Yes, Mohanty sir, please.
Hemant, one message. Actually, I discussed this NRP with Dr. Devrari. Okay, how do we go about it? See, 40% of population are children, and we saw how many neonates are born in every taluka, and how many pediatricians we have in taluka level. We have government of India also admits this deficiency, the gap area, that we have to train doctors, general doctors, and maybe nurses on the neonatal resuscitation. And they have agreed that up to bag and mask, people can do it. It's not a big rocket science.
Yes.
I have tried this again. I'm saying, one girl was with me for her PhD in nursing, MSc pediatric nursing.
Yes.
Working as a PhD, and I involved another 5 people with her. And from selected taluka of Raigad district, we have implemented this. First, we trained them on mannequin, then trained them on the site where the delivery is occurring, and then at the site of the primary health centers. So, and there we saw their video recording. What is the correctly, how many people are doing that? And it is, if they are trained and repeatedly they keep on doing it, they can do it. It's doable. So the government also should think to bridge this gap of the manpower gap, skill gap, by training more and more people. Without that, we will never achieve our desired goal.
Yes, sir.
It is doable. Certainly doable.
Yes, sir. Yes, sir. Dr. Sachin is there. Sachin does lot of this research. Sachin, we can share our experiences because you have the critical care and you handle so many newborns. If Sachin, you are there and you are audible, if you are hearing me, our president of IIP Raigad, they face day-to-day problems of this. Sachin, are you there?
Sachin Murade sir?
I think so.
I think so is not. So today we had a very fruitful session.
Neha, anyone, Dr. Mahesh or Dr. Madhavi want to contribute or to say something?
So I want to acknowledge the presence of Dr. Mahesh Salonke sir and also Dr. Madhavi Ingle ma'am.
Sulakshane, not Salonke, Sulakshane.
Sorry, Sulakshane. I'm so sorry.
No worries, no worries. I'm used to this.
Yes, sir. Please.
I think excellent session. Both the sessions were excellent. The experts' comments were also excellent. The initiative by the Raigad IIP is excellent. I think we will look forward for the next journal journey. All the best to the team Raigad IIP and Maha IIP. Thank you so much.
Yes, ma'am. Madhavi ma'am.
Very beautifully taken. I think postgraduate students also need to get more and more engaged in such programs because in spite of we at this age are learning so many new things. So these are definitely new points to be applied for day-to-day pediatricians, college, academicians, everyone. Very well done.
Guru
Thank
Prasad,
you, ma'am.
acknowledge the presence of Guru Prasad.
Yes, sir.
Thank you, Hemant sir. Thank you, Anand sir. Thank you, Samruddhi, for a good presentation. And thank you, Swapnil sir and Hambir sir also who presented very nice. This is the first journey, and as I'm first EB here, I just very excited to watch this journal reading, and it's a very nice presentation and very nice. Thank you, IIP, Maha IIP and IIP Raigad. Thank you, sir. Thank you for giving me the chance.
Neha, with your permission, because we had today good experts, presenters as well. In fact, experts, and one of the presenters is also like an expert only.
Yes,
So
sir.
all three people, if you feel any article which is worth discussing journal journey, you can please share with me, Mohanty sir, and you can also suggest the presenters, experts, but we want this to grow and grow across the state and across the country. So you can always suggest the articles which are practical, useful for the, and you can connect with Dr. Mohanty sir, because every time Mohanty sir gives us the article well in advance, and then we work on it, and lots of thanks. Means we should always appreciate the efforts of Dr. Chitra Kulkarni madam and Dr. Neha Singh madam. They are the main backbone of the journal journey, well supported by our mentor Dr. Nimen Mohanty sir. And yes, Neha, if you want to say anything, otherwise I will give the vote of thanks. You don't worry.
Neha to suggest the next journal journey topics.
Yes,
I
sir.
think we have the rest.
So our next journal journey for March, the articles have already, Niman Monti sir has suggested. First is intranasal treatment for children with sleep disorder breathing, which will be presented by Dr. Alankrita Agarwal from IIP Mumbai. And the second article is advances in newborn screening, which will be presented by Dr. Mimansa Paraskar from IIP Nasik.
Yes, Dr. Mahesh sir as well as Dr. Guru Prasad, he can also contribute the articles, present us everything. Please help.
100%, sir. We will do that.
Yes.
Yes, sir. Yes, sir. Yes, sir.
Thank you.
Thank you. Thank you. Thank you, Neha madam. Thank you, sir, Monti sir, Chitra madam. Mostly boosted all the newcomers. Samruddhi appreciated madams and Anand sir also appreciated for all this. Thank you. Thank you, sir. Very nice.
So
Thank
just
you.
to make the thing formal, vote of thanks should be given by someone. And all the time the Neha is speaking, so I will just give the vote of thanks. Thanks a lot to both presenters, the Dr. Samruddhi as well as Dr. Tejas sir, and experts Dr. Anand and Dr. Swapnil sir. And also to grace this episode, Dr. Mahesh is there, Dr. Madhvi is there, Dr. Guru Prasad is there. In between, Dr. Renu was there, Dr. Sanjeev was there, and everybody who is there, Dr. Sachin is there, Sachin Murad is there, and all office bearers of the Maha IP as well as IIP Raigad and all the CIP, whoever were present or in absentia. And so we thanks a lot. And last not the least, our mentor, Dr. Niman Monti sir, thank you very much for sparing your Sunday, as well as Dr. Neha, who moderated this session so very well. Thank you, everybody, and good night to everybody.
Good night.
Thank you.
And
Good
thank
night.
you, Pallavi ma'am,
Good night.
for the
Thank you.
technical support.
Pallavi madam, Dr. Pallavi. Yes, Dr. So she has become Dr. Pallavi madam, thank you very much. Yes, by
Thank
that,
you.
good night. And Pallavi, you can end the meeting. You can stop
Yes, sir.
recording.
Thank you.
Good night.
Good night, everyone. Good